Okay, good evening, everyone. And sorry to keep you waiting. I'm not completely sure what's going on, but I've prepared a short presentation. And thereafter, I think there is time for discussion. And what I wanted to share with you is the experience we had at UCLH and my personal experience in the past few months when we were dealing with the peak of coronavirus patients in London and in UCLH in particular. It's interesting to look back in the last, it's only 4 months or so, what has happened. And I'm actually most impressed by the fact that a very small virus, which is only 1/10,000th of a millimeter and only has 15 genes, was able to completely change the world and to put everything upside down. So it makes you humble, probably. And I think we're still in the middle of all this, although I'm also quite optimistic, but I'll reserve that maybe for the discussion, that there will be a way out and that we have actually had the most difficult behind us. So this is a picture of January of this year, half a year ago, and you may probably recognize this. This was when the coronavirus epidemic at that time started in China, in Wuhan. And we didn't know exactly what was going on, and it was a bit spooky, and everybody was questioning what was going on. But suddenly they were building from scratch, a totally new hospital in a way that we thought that only Chinese people could do that. And everybody was impressed, but it was far away, and it was actually not really relevant to us, it seemed. But shortly after that, in February, suddenly the virus arrived in Europe. And there were many, many cases in Italy and later on in Spain. And we saw these spooky images on TV, and we were reading about it in the newspaper. But although Spain and Italy are much closer to the UK than China, we were still thinking that this was something, well, remotely. And not clear whether this would reach the UK. And that thought was actually reinforced by our government, who at that time thought that this was not really an issue and that we should not panic and that we could actually contain all this before it would be a big problem for the UK. I was quite fortunate to have worked in Italy for a couple of years, a long time ago in Perugia, with Professor Giancarlo Agnelli, who's quite a famous doctor and researcher in the field of acute medicine and vascular medicine. And I know him very, very well, and we became very close friends. And when I was working in his university and in his department as a young doctor, I worked with Flora Parvandi, who is actually now the professor of medicine of the University of Milan and chief of the department. And one of the other collaborators was Anna Falanga, and she is leading the Department of Medicine of the University of Bergamo. So I was emailing with them, and they actually told me that this was quite an impressive thing, that it was something to take very seriously, that the overwhelming of Italian hospitals had not so much to do with how the Italians have organized their hospital care or healthcare, but that this was a very aggressive virus that caused a lot of very, very serious disease, and that we should better prepare ourselves and not lose too much time until the virus would reach the UK. And at the same time, I received a visit from 3 young intensive care doctors from UCLH. Here you see Kevin Fong and Jim Down and Rick Thomas. They're all working on our ITU, and they have a special interest in emergency preparedness and emergency medicine. And they came to me and they said, we really have to prepare ourselves, because according to our calculations, this is going to get completely out of hand. And London can be easily overwhelmed by so many patients that we cannot deal with them, both in terms of intensive care medicine and in terms of hospital care. And I think that proved to be right. And we started to have all kinds of meetings, mostly in the evenings and on weekends, with a lot of people, and they all showed up and had very good discussions on how we would prepare UCLH for this very large peak of patients. And of course, at the same time, we had our meetings with the NHS and with the UK government. But to be totally honest, we were not taking really seriously at that time until indeed the virus did hit the UK. The numbers were increasing very rapidly. There was a doubling time of 2 or 3 days. So it was not very easy to calculate that we could be overwhelmed if this would go on forever. And that led to the maybe rather late decision of the Prime Minister to start a lockdown in London and the rest of the UK, which turned out to be the most effective way to contain the virus. But in the meantime, we had, of course, a lot of very seriously ill people that needed care and attention, and sometimes intensive care. So the plans we were making were actually quite extensive and comprehensive. So we calculated that we needed to quadruple intensive care capacity in UCLH, and that we needed a lot of hospital beds in our hospital. So that actually meant that we needed to repurpose a lot of wards and prepare them for very sick patients with pneumonia and related disorders, isolation space. The emergency department needed to be completely redesigned to actually safely receive those patients and to triage them for the most appropriate treatment. We even had to do a little bit of building work to restructure floors, to have doors and new entrances, and to make changes to the building. And then, of course, to make space, we had to move a lot of ongoing activity to other sites. And we are quite fortunate in London and certainly at UCLH to have different hospital buildings. So, for example, we could move our entire pediatric department 2 floors in the tower to Great Ormond Street. We could move the stroke services to Queen Square. We moved all cancer surgery to Westmoreland Street Hospital, not only for us, but also for all the other hospitals in North Central London. And we also moved services to the independent sector, where there was a deal between the NHS and the independent sector. And I think we were very gratefully using that capacity as well. But that was only space. Of course, we also needed doctors and nurses. So a large part of the clinical workforce needed to be redeployed. And this was not only true for the nurses and the junior doctors, also most consultants were redeployed, in particular the medical consultants, but also the surgical colleagues did a lot of work on ITU, supporting the ITU staff and all the activity that was going on there. So that was quite a lot of work. In the meantime, we find it important that we could also offer some degree of emergency services for non-COVID care. I already mentioned cancer surgery, but of course also urgent neurology care or other urgent medical care needed to be secured one way or another. And I think we have been able to do that. We have an electronic health record system since exactly 1 year in UCLH. That means that everything is connected into one system. And most of you will probably realize that also a lot of the readings from ventilators, from monitors, from all kind of recording systems for patients automatically enter into that system. So if you change the complete setup of your hospitals and you're going to move the equipment and machines and wards, you have to change the electronic health record system as well. So that was a separate work stream. Virology testing was a huge problem. So how can you treat hundreds of patients with a viral disease if you do not have sufficient virology testing? So you don't even know for sure they have the diagnosis. And I'll come back to that in a second. And of course, a very large part of our staff had to work from home. But they could only work from home if we afforded them with the technology, with laptops, with access to databases in the hospital, with telephone lines that needed to be diverted to their homes. So that was also something that needed to be organized. There was a lot of issues about staff protection and about the availability of personal protective equipment, as you know. But even more so, staff was really concerned and worried about what would this mean for them if they would work in the front line and taking care of patients, but also taking a risk themselves. And not only they were worried, they were of course also worried for their families, and their families were worried about them. A lot of our staff is working with more generations in a household or very close to their parents. And they were really concerned what it would mean for them if they would take a risk and work in the hospital. And many of them choose to use a temporary accommodation that was offered by us in hotels and in apartments that were available not far from the hospital. But we had almost daily information meetings. And usually if you have an information meeting, then 50 or 60 people show up. But in this case, hundreds of people came to the information meetings. But we soon realized that we also needed dedicated information meetings for our cleaning staff, for the porters, for security, because those colleagues do not automatically come to information meetings because they feel a little bit out of place if they go there. So you need separate meetings for them. So a lot of time was spent also on proper information and communication with staff. And there were all kind of other issues, security, access to buildings, visitors, etc., that needed attention. So how did we deal with that? It was actually quite a complicated puzzle because everything has to do with everything. And a lot of things were happening at the same time, and we had to prepare a lot of things. And the question that was often asked is who is going to do this? Who is going to do all this work? Who's going to do all this preparation? Well, I thought about this a long time, and I was sure of at least one thing. I think nobody on this slide was going to do this. We could not expect that any of these people would offer any significant help to us. So the best thing to do was actually to do it ourselves. And in particular, I'm always convinced that if difficult decisions need to be taken or major projects need to be done, then we actually need to rely on the professionals. So we've very heavily relied on our clinicians, on our doctors, on our nursing staff, on our allied health professionals to do all this. And to put them in the lead and to actually ask them to come up with ideas and solutions for all these problems that we were facing. And that was exactly what happened. And I think it was that was a good thing to do. We only told the professionals what we thought we would need. And they came up with plenty of ideas how to do it, what would be the best thing to do. They didn't have to ask for permission to the board, to me, to anybody. They just were able to make these changes. Managers were actually put in a much more supportive role suddenly, and were assisting the clinicians with all these ideas that needed to be realized, and played a very important role in that, much more logical role for them. And actually the encouragement from our side was that everything needed to be result oriented. So not doing your best was just not enough. It was all about realizing these extra intensive care beds, these extra hospital beds, these extra emergency care spaces, virology testing, infection control, and so forth and so on. And the only thing what was quite directive from me was that I said that I didn't want to see any PowerPoint presentation during these weeks. We were just going to do things and not make slides. And that actually brings me to a more philosophical thing, thinking about leadership. Many people actually thought that many people think that leadership is something that is all about the top, and that the rest of the organization needs to support the top, and then everything will be all right. But I tend to have an alternative view. I think leadership and making important decisions has nothing to do with being the boss. That simply does not work in a hospital. And fortunately, it does not work in a hospital. I see it much more as being a conductor in a symphony orchestra, where there are fantastic musicians in hospitals, clinicians, that can play their instrument, that can really do fantastic things. But if they actually work together, if they play together, then the end result is so much better than the individual thing that all these musicians have to offer. So it has nothing to do with power. I think that's totally misplaced in a hospital environment. It only has to do with influence. A conductor of an orchestra has no power, but he has a lot of influence. He can nudge musicians in the right direction, and he can let them collaborate so that actually the result is a result which is very good. And that led to the one team approach, so that we found it really important that people work together, were working as a team, crossed boundaries of disciplines. So there were doctors supporting nurses, there were nurses supporting allied health professionals. I think we paid much more respect to cleaners and caterers and porters than we would normally do. And that actually had an enormous synergistic effect on all the changes that needed to be made. And it's actually interesting if you think about the role of the managers. And I think about managers in a hospital organization quite often. And if you Google healthcare professional and you look at images, you get this very cozy white, blue type of picture. But if you type healthcare manager into Google, the screen turns black. So it seems that there is a large schism between the professionals and the managers, and they even have a different color. And I think that's very often because we speak a different language. The language that's been spoken by managers is very often not even understood by the clinicians, but it also works the other way around. The priorities and the language that's being used by clinicians is often not understood by managers. And I think when with this one team approach and with this result-oriented approach and putting clinicians in the lead, when we realized that, the managers became much more effective and actually enjoyed being in the role they were put in instead of their usual role. Well, lastly, we had another trump card, I think, at UCLH, because we are an academic hospital and research and innovation is very close to our heart. And we are, of course, in the middle of this fantastic part of London with so many academic and university organizations. And I'm going to show you two examples that really made a difference and were game changers in our response to the virus epidemic. This is a picture showing the story of Mervyn Singer, and I realize he's going to talk to you next week, so I'm not going to steal his thunder, but just to, as an intro, he realized he's a world famous intensive care doctor. Most of my research is taking place on the intensive care, and wherever I go in the world, everybody knows Mervyn, and he knows everyone. So he was also chatting with all his colleagues all over the world, and he quickly came to the realization that non-invasive ventilation could mean a lot and could actually be a game changer and keep a lot of patients from the ventilator with all the associated problems. But we did not have enough non-invasive ventilators. So he redesigned an existing very old device, the whisper flow from Philips from the Netherlands, and totally renewed it with the help of UCL medical physics and biomedical engineering, and with very innovative help from the Mercedes Formula One engineers. And not only they were able to produce a non-invasive ventilator device in a very short amount of time. It was tested in humans, it was tested in patients, it was approved by the MHRA. And actually, the design was made available on the web for other countries that also wanted to make this, and it could be mass produced in a matter of days. And thousands of these devices have been produced and have made a massive difference in many hospitals across the UK and now across the world in the treatment of patients with coronavirus with non-invasive ventilation. So a fantastic example of innovation. And another example came from the Crick Institute, which is just down the road here from UCLH, and in particular Charlie Swenton, who is one of the brightest people, I think, that work both at the Crick Institute and at UCLH. He's a pulmonary physician and researcher. And he designed a completely new virus test using chemicals that were available, because that was the limiting factor at the time. And he was able to scale it up. And actually, the Crick is now, since March, April, is doing thousands and thousands of virus tests, not only for UCLH, also for the Royal Marsden, for the complete North Central London and Central London organizations of healthcare, for GPs, for London ambulance services, and so forth and so on. And that was a massive game changer, because the availability of a lot of testing, and later on they developed also antibody testing that was reliable, really made the handling of this virus epidemic much easier. So it's been a very intense past few months, it's fair to say. I think the whole world now is in the van of the coronavirus. That's not a surprise. We have learned a lot. And actually, and maybe that's something for the discussion, what I learned is that a lot of the things that we were observing, from epidemiology to reorganization of services to repurposing of equipment, was already around, but the coronavirus epidemic is a kind of a magnifying glass that makes everything much more visible and provides therefore much more insights on how we are doing and how we can do better in healthcare and dealing with very sick people. So thank you very much for your attention and very happy to take any questions.
Well, Marcel, can you hear me? David Katz here. Can you hear me?
So now I'm a bit puzzled who is going to moderate the questions.
Can you hear me? Can you hear me?
David, I can hear you, but I'm not sure anybody else
David,
can.
are you on the line? I can see you're muted.
I'm unmuted.
I can hear you, but nobody else can.
Okay.
That's very strange.
Is there no way of logging me on?
I'm worried if I do that, I'm going to close the meeting early.
Abigail says, well, you can hear me. You can hear me now? Everybody else appears to be hearing me except for Marcel.
That's what it looks like.
The only person who, can you tell Marcel that the only person who can't hear me is him?
I can hear you now, David. Thank you.
You can hear me now?
Yeah.
Perfect. Okay. Well, first of all, what I was going to say beforehand, I think is what I was going to say before you started was that the one thing that struck me when we first met was that you'd been, your father had told me about you a very, very long time ago in the context of Jewish medical affairs. And I'm very pleased that we've been able to get you to come along to us tonight as a kind of debut in the Jewish medical affairs in the UK. And it's taken the virus to actually get this together. So we've got something to thank the virus for, even if we're not thanking it for other things. The second is that you create, the one thing that I was going to say in introduction was you create a sense of security and confidence. And I don't think you should underplay that. And I think everybody on this Zoom tonight will have seen already from the way you've presented that story and the modesty with where you've presented that story, that that's absolutely true. Now that's normally the things that are said to thank you at the end, but I'm going to now carry onto some of the questions that have come up in advance, and I'm going to start with the two more philosophical ones. One of them is the question, can all viral infections potentially lead to this kind of cytokine storm and this kind of situation? Is this a feature of all kinds of viral infections and just happens to have happened with this one?
Oh, wow. Well, thank you. That's a nice question. I'm not the viral disease expert here, but certainly, like many microorganisms, yes, you can have an excessive inflammatory host response that is actually worse than the infection itself. But I think the number of people that suffer from this affected by coronavirus, and it was not very different from SARS, which is just a very close coronavirus infection, similar pattern, but it was much easier to contain, I think, when it went around in Asia and Canada in particular. So I think, yeah, it is a particular feature of coronaviruses. So, but not extremely uncommon. which is uncommon, and that's, I think, was also for me an eye-opener, because I'm interested in hemostasis thrombosis, is the enormous effects on clotting and thrombosis.
Well,
Excuse me. And I think the mainstream thinking now is that this virus, like any other coronavirus, can directly infect endothelial cells and directly cause vascular disease. And that's also a link to why people who already have sick vessels, for example, due to diabetes or hypertension or other risk factors for arterial disease, have such a worse outcome. It's probably all related to vascular complications in these patients.
right. Okay. Well, as you've started on the vascular complications, there are a couple of questions about vascular issues. One is, people with antiphospholipid syndrome, would they, if they got COVID-19, would they be at greater risk or at less risk? Or
Yeah, we don't know, interestingly. So we don't even know for the more common thrombophilia syndromes like factor V Leiden or prothrombin 2 or 2R210 mutation. And we certainly don't know for antiphospholipid antibody disease. It's not overwhelmingly a risk factor. So we do not have massive numbers of patients with antiphospholipid syndrome who suddenly turn up with the most serious COVID-19 infections. But maybe the numbers are too small to really tell. But it's not huge, I have to say. Maybe because these patients very often are already on anticoagulants and have some form of protection against thrombotic complications.
right. I mean, one question came from somebody who's actually recovered, one of our geriatrician members who's actually recovered and was in hospital for 6 weeks. And he's actually been on, what has he written down? Apixaban. He's been on apixaban, and he wants to know about that. And what about the risk of thromboembolism when he stops?
Yeah, okay, good question. So apixaban is a very good anticoagulant, but it's similar to warfarin or to heparin in therapeutic dose, or to rivaroxaban. It's anticoagulation, and it seems to be effective for prevention and treatment of thrombotic complications, also in most patients with COVID-19. Yeah, what happens when you stop? Well, the academic answer is we don't know, because we haven't had any trials. But I can also give a practical answer. I think the thrombotic complications that you see with COVID-19 is a classic example of provoked thromboembolism. And we do know that the risk of recurrent of provoked thromboembolism is low when the underlying cause, in this case COVID-19, is gone. So if you're otherwise in a reasonably okay condition, the COVID complications are gone, then after a few months, I think it's absolutely fair to stop anticoagulation.
Thanks. We have another member, rheumatologist, who of course asks the question, kind of all the drugs that are in favor, hydroxychloroquine maybe, dexamethasone, all of the ones are used in rheumatological conditions. What about the TNF-alpha pathway, the TNF-alpha blockade, and what about those drugs? Are they drugs of any use at all?
Yeah, so there is the most information we now have on drugs interfering with IL-6. Tocilizumab is an IL-6 receptor antagonist, and although it's not the dreamed randomized controlled trial, but there's a lot of retrospective semi-controlled trials that do show that in the most severe patients, interference with IL-6, there's also an anti-IL-6 monoclonal antibody from India that's being tested now, seems to have an effect. So that's promising. The most recent anti-cytokine drugs that are being used in rheumatology, like baricitinib, for example, is also now being tested in a randomized controlled trial in patients with severe COVID, mostly in the United States, because they have a lot of COVID, and in Brazil, whereas in Europe, you can't hardly do any trials anymore because there are not enough patients at this time.
Right. Well, some of the other questions on the more philosophical side, one relates to the question of how do you see the future relationship between the doctors and the managers evolving, and what's the impact of this this episode going to be on that relationship?
Yeah, so I was already convinced before COVID, but I'm even more convinced after COVID that the only way to run a hospital is to put professionals in the lead. And I'm not saying that means that you don't need managers, and you need, of course, people who have expertise in money and accounting and organization and workforce. But it needs to be a one-team approach, and the clinicians should be in a decision-making role. So it's not enough for a doctor to say, well, I'm a very good doctor, but I just see my patients, and for the rest, I'm not interested what's going on in the hospital. It's a two-way street. If we put clinicians in the lead, clinicians need to take responsibility for everything that happens in the hospital. And I think that's a governance model that absolutely works for me.
Right. How similar is it to the governance model that you had in Amsterdam? Was this the similar model that you had when you were working there?
Yeah, I think we experimented a little bit with it in the Netherlands, and my predecessors there as chief executive started to do this, and I think I was quite keen to do the same, and there it worked really well. The big difference with the UK, though, is that in the Netherlands, it was mostly doctors in the lead. And what I found in the UK is that we have a very, very strong nursing discipline who are in many cases very advanced, take very strong leadership roles in the hospital. And the same is true for many of our allied health professionals, physiotherapists, or even dietitians or other disciplines. So as long as it is people who work in the hospital with patients and who understand what's important for patients, I think they are all the people that we need to rely on in leadership positions.
One of the issues that arise from that should there be management training for doctors, and should it start, how early should it start in their careers?
Yeah, so absolutely. So it's not part of the medical school curriculum, but I give a lot of talks for junior doctors and even for medical students who are massively interested in learning about this, because they want to have more control about their future and how their work is being organized. And the only way to do that is to have a role as a medical director, but also maybe as an operational director in the place they work. And they need some training. But you can, well, from my own experience, I can tell you, I never did an MBA or a lot of formal training. I had a little bit of training and a little bit of reading about all this. Most of management is common sense. And actually a lot of things that you learn in medical school and in clinical practice, how you deal with your outpatients, how you run a very busy emergency department as a doctor, is not very different from management. It's so a lot of the things that you already do very well are very applicable to running an organization.
One of the questions that this whole episode has brought to the fore is the question of the duty of care and responsibility to staff. And one of our senior public health doctors has asked the question, what, beyond just payment of death in service to anybody who has been harmed or hurt or ill as a result, what are the duties that the hospital has and the organization has to them and their families?
Yeah, so it starts with proper protection of staff who works in the hospital before terrible things happen to people. So, and I think it's very important that we make that a priority, and that we, at all levels, that we express that we find this a priority. I remember very difficult discussions with our resuscitation team, and we had a lot of resuscitations, unfortunately, with the very sick COVID patients, that we said, you cannot go into that room until you are properly dressed with protective equipment, even in case of a cardiac arrest. And if that would mean that the patient has less chance of survival because there is a slight delay, that's what it is. And many professionals found that really difficult, because that's not the way we're trained. We're there to help people and to save their lives. And very often we do not prioritize our own safety, but I think it is important we do so, because if we don't, then we will all be sick and ill at the end, and there is nobody to help anybody else anymore. So that's part number one. Then part number two, of course, is those who have been so unfortunate to contract the virus and have a permanent harm or even die of it. I think we do have a responsibility as an employer, but maybe in a broader sense as an NHS system. And although the numbers are not huge, each and every colleague counts, I think. So I would go really far to take that responsibility and to do whatever we can to support those people or their families.
Presumably it's an occupational exposure which goes beyond the doctors and the nurses. It actually goes all the way, as you've emphasized, down to all the staff of the hospital. Is that a correct interpretation of what you've said?
Absolutely, but what I've really learned I learned a lot in the last few months. But what I learned is, so so it's a one team approach. So the cleaners and the caterers are as important as the nurses and the doctors. We already knew that, but that became blatantly clear once again. But they speak another language as well. So you also need to approach them differently. And the way you talk and you can reassure doctors and nurses is different from the way you can reassure people who are sitting behind the desk and are afraid that they will get the virus from people talking to them, or people who have to clean rooms where a very sick coronavirus has been in or are still in. So, but to many wards at UCLH actually took the very wise decision when they had a team meeting to also invite the support staff of the ward, the porters and the cleaners into these meetings, even when it was not always maybe directly related to them, but to give them a feeling that they were part of the team. And I think most people really like that.
One of the questions which that raises, and both in the patient cohort and in the staff cohort, is the question of the disproportionate impact on the BAME community in this country. I wonder whether you have any reflections on that in relationship to UCLH.
Well, yeah, no, I don't think there is a specific position at UCLH. For me, this is a classic example of the magnifying glass. So we already know that BAME people have much worse health outcomes, that they have less access to healthcare than other people have, that there is actually a difference related to the color of your skin on how you do in hospital. But this is only massively magnified by the COVID-19 epidemic. There may be some additional genetic risk factors. And there are, of course, social issues, so multi-generations living together in one house, for me, probably makes a difference. But there is also a large socioeconomic issue that was already there, but is now extremely clear.
The questions are pouring in. How would you prevent a second peak?
Well, so take it or not. I'm not the expert here. I'm quite optimistic. We will see it coming, and we know now so much more than we did in March, and we have widely testing available, and we not only antibodies but also virus antigen PCR. We understand how we treat patients. Interestingly, the patients that are currently being treated in hospitals in the UK do much better than patients in the initial phase. There must be a learning curve. Please don't cite me because the press is not yet after it, but we know that everything in medicine has a learning curve. So why shouldn't treatment of very sick COVID-19 patients not have a learning curve? We will see, in my view, clusters. We will see outbreaks. We will see peaks of patients, and we will have to respond to that with partial lockdown or with other public health interventions. But I do not think we will have the massive outbreak we were seeing in March, just simply because we know so much more. And we know how to deal with it, and we will see it coming. And countries that eased the lockdown weeks before the UK also do not see massive numbers of coronavirus patients again. So the second thing that makes me optimistic is vaccination. I do not know of any viral disease of a non-mutating virus that generates antibodies and that seems to generate antibodies upon vaccination that cannot be safely prevented. There is simply not another example in medicine. So the antibodies will protect people, maybe altogether against COVID-19, maybe it will protect them against the more severe forms of COVID-19, which is fine with most people, I guess. The only thing we do not know is for how long this protection will be, how quickly the antibodies will disappear. But it's not only an antibody story. The immunologists will tell us that there is also something like T memory cells, and that it might well be that that people who had the disease are protected for the more severe types of COVID-19 for the rest of their lives. Another encouraging thing that nobody talks about is that the first peak of COVID-19 in China occurred in January. Millions of people have been affected. There is not a single case in the literature of reinfection. So if the antibodies would not be protected, or if your immunology system would not be protected, we would have seen a lot of reinfections in the meantime, but we don't see that. So I'm quite optimistic that the vaccines that are under development will work and will be a way out of this very difficult situation.
That's it's an interesting question because there's quite a lot of interest. First of all, should the advice about masks be upgraded so that more people should have the higher level masks than just the one surgical mask that's being used? Should that advice be changed?
I don't know. I'm still curious what happened with the masks. I think the real experts and the scientists will tell you that the evidence for wearing masks is paper thin, and that it was mostly a decision that was taken under political pressure to introduce masks. And what I see, just on the streets or traveling in public transport or in shops, is that the way people deal with masks actually makes them at a higher risk than not wearing masks at all. So, but that's my personal observation.
There are two questions about children. Why do children not get the disease at least in this form? And the second is, what about the question of children going back to school?
So there's lots of theories why children do not get it. It may have to do again with endothelial cells. So endothelial cells of children seem not to be infected by coronavirus. So that may be part of the puzzle. They may have another immunology makeup, and they may have a less severe inflammatory response to coronaviruses. So, but yeah, I think the epidemiology tells us that children very rarely get ill from this disease. The big question still is, can they carry the virus and can they transmit it to other people? And I think that's part of the school question also. If we open the schools, are we opening a reservoir of young people carrying the virus, not becoming ill, but actually infecting their grandparents and other people? We probably don't know. But again, in many countries, schools have reopened weeks ago, and it did not lead to an explosion of virus infections.
Right. Well, talking about the comparators with many countries, one of the questions that's been raised is that is it possible that we were too restrictive in the UK in admitting patients to intensive care units because of the overwhelming experience in Italy and Spain that was in the media at the time?
Yeah, I'm not sure it would have made a lot of difference. So if you look at, we have now strong figures with all those patients about prognosis of patients with lots of comorbidities, very high age, and many other medical problems. And they were extremely bad when they needed intensive care for COVID-19. So it is a bit difficult to say, but maybe the difference would have been if we would have admitted more of those people to the intensive care, that mortality would have been the same, but we would just have added a lot of days of a lot of suffering and very intensive treatment without any positive effect for them onto them. So I'm still very much behind the way the UK treated the epidemic, that we actually made the decision not to admit everybody to the hospital and everybody to the intensive care. We know that in severe epidemics, more people die of other causes than of the infection itself. And we also know, and that's also very cruel to say, but it is a fact that the majority of patients who died had a very short life expectancy. I mean, the patients who died in care homes and not on intensive care had a very short life expectancy, so which was shortened by the virus, but not to a extreme significant amount. So I think we took a wise decision, and we may have prevented a lot of suffering on intensive care for those patients.
In that case, the follow-up question was from the same doctor was, well, why has the UK still got one of the worst per million death rates? And was that possibly a function of time and timing of lockdown and so on?
I don't know. So that's a difficult question. It may be a result of the lockdown, but maybe we should also remind ourselves that the general health situation in the UK is not one of the best in Europe. And I think even before the COVID epidemic, people like Michael Mermott had brilliant papers demonstrating that there is a very large group of very unhealthy people in the UK due to socio-economic circumstances. So it may be much more a reflection of that than of anything else.
I think there's really one final question, which before we're going to let you go, and which is really, if there's one lesson, the most important lesson you've learned as a leader during this pandemic for yourself.
Well, to be honest, I can easily tell you 10 lessons I learned, and probably even more. But what really comes to mind is that an organization, even of the size of UCLH, it is a big organization, works so much better if decision making is done as low as possible in the organization. And we always have a tendency to escalate things and to say, well, you know, that needs to be decided by my supervisor or by the clinical director or by the medical director or even by the chief exec. But that's only going to slow you down. And if you really think it's a good decision, you better take it. And if it turns out to be a wrong decision, well, that's not a bad thing. I think it's worth not taking a decision. So I'm even more enthusiastic than I was before that decision making should take place as low as possible in the organization.
And of course, one question comes in immediately while you're talking, which says, and what about the Nightingale hospitals? And, you know, decision making and all the elements.
Yeah, hindsight is always, you know, easier. I will be totally honest. I was not extremely in favor of the Nightingale hospitals because I thought at the time they were actually created that we already saw that the hospitals, the normal hospitals could deal with this. But I was not 100% sure. And I see it as an insurance policy. We paid a lot of insurance premium for something that we didn't need. Well, better than the other way around. If we would have needed it and it would not be available, that would be a disaster. So I pay insurance premium for fire risk in my home, but I'm actually not unhappy that I never have a fire. So I think we should actually not complain about these things. It was an insurance policy. We didn't need it. That was actually quite fortunate.
I think that if we want to be our insurance policy at UCL and UCLH may well be what we've heard tonight and what we've seen tonight and the way you've handled the questions as well as in your presentation. Our insurance policy is that you're there and looking at this and thinking about these things that you've been speaking about. So I'm sure I speak on behalf of everybody that's been able to participate to say thank you very much. And thank you very, very much for sparing the time in what is an incredibly busy schedule.
Well, thanks for having me. It was a pleasure.
And we hope we hope we'll have you with us again at future events.
Thanks. Bye.